Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. wildhealth.com for all the information on becoming a patient or working with us. Good morning, June 12th. Thanks for listening to the Wild Health podcast. There's over 2 million cases of coronavirus in the United States and about 115,000 deaths. Data from the Financial Times shows that the 7-day rolling average of coronavirus deaths in the United States remains at about 4,300 per day. It's staying pretty steady. The decline in Europe and the United States has been offset globally by rising numbers in Central and South America, which are almost half of the average daily global deaths now. Brazil, who we've talked about before, they've had a couple days of reporting less than 20,000 new cases. They resumed their sharp rising upward trajectory, and they had more than 32,000 new coronavirus cases in the past day, which is the second highest daily incidence yet.
It's important to remember, Matt, that even though the deaths in the U.S. have remained pretty steady, with this newest spike that we're seeing from opening back up, that's going to be delayed by potentially 7 to 10 days before we start seeing any change in the deaths. So a lot of people are using deaths to estimate how bad the disease prevalence is, and it is delayed by 7 to 10 days on a pretty consistent basis.
Yeah, and as we talked about in our last update, though, we are seeing an uptick. Places like Arizona and Texas had pretty big upticks. Like when I look from 2 weeks from May 26th to June 6th, they went from deaths of 1 to 30 in one of those states and 9 to 30 in the other. So we are starting to see some of that as well, because it has been a few weeks since we started relaxing the social distancing orders and started having crowds like in Memorial Day weekend. So in the past 2 weeks, at least 23 U.S. states have experienced a rise in cases. 5 states have doubled their daily incidence over the last 2 weeks, and 14 states have reported their highest 2-week average incidence yet. Other reports show that COVID-19 hospitalizations across the country are rising as well, suggesting that the growing case count is not due to increased testing, which is one of the first things I thought about when I started seeing the spikes. I thought, well, maybe we're finally catching up on testing, but it seems the hospitalizations and deaths are actually starting to rise a little bit as well, and there's some actual new clusters of cases or resurgent waves.
All right, so in research today, I've got one interesting study to talk about. This is interesting to me because it's associated with genomics. This is a large genome-wide association analysis, and the name of it is the ABO blood group locus and the chromosome 3 gene cluster associated with SARS-CoV-2 respiratory failure in Italian-Spanish genome-wide association analysis. This is preprint. It's released on June 2nd on medRx. So it's a pretty cool study. It's a lot of patients, so 1,980 patients with respiratory failure COVID-19. So these are severely ill COVID-19 patients from 7 different centers throughout Italy and Spain, which were epicenters for SARS-CoV-2, as we know. And what they did is they did a genome-wide association analysis. So they looked at about 8.5 million single nucleotide polymorphisms and tried to associate those with severity of disease. And they didn't come out with many. And previous studies that we've seen that have looked at this have specifically tried to isolate ACE2 enzyme SNPs, and they haven't found any association with severity of disease. But these guys found 2 SNPs. One is RS1138592, which is associated with a gene called SLC6A20, and another one is RS657152, which is associated with the ABO blood group. And both of these were significant in terms of disease severity for COVID-19. The odds ratio for that first SNP that I talked about, the SLC SNP, was 1.7, and the odds ratio for the ABO blood type group was 1.3. And this is interesting because this is data that you can actually collect from, say, 23andMe or Ancestry, at least the ABO blood group type. Or if you know your blood group, it could actually be meaningful. And basically what we found is you've got about a 50% increased risk for severity of disease if you're a type A positive blood type person. And if you've got type O blood, your odds ratio is 0.65, so about a 35% decreased risk of disease severity. So while you can't really just go to 23 and look up your RS SNP 11385942, the SLC one, you can look up your type O blood SNP, or if you know your type of blood, then you've got that data in front of you. So this is interesting. Just an association study. Obviously, association does not necessarily mean causation, but the reason that they think this makes sense is because both of these SNPs are very close to the ACE2 enzyme gene. So they're not actually part of the ACE2 enzyme gene, but we think they're somehow playing a role in the way the ACE2 enzyme is either coded or it presents itself on the cell surface. There's probably some interaction here based on its location in the genome.
So someone can just search this in the raw data and tell what their blood type is, right?
Exactly. Yeah. So if you pull down your raw data from 23andMe and you open it as a text file, you can hit Control F and type in RS657152. And if that is, if the result you get back is D, then you've got type O blood. And if you don't get a result back, or if you get an I back, that means you're probably type A or type B. And it's a little more complicated to figure out whether you're A or you're B. But if you're type O, you'll get a DD back.
And I'm just asking for a friend because obviously I know my blood.
You know exactly what your blood type is, right?
Is it too embarrassing to admit that I don't? The funny thing is I in college sold plasma quite a bit to make rent, and I've donated blood multiple times, and I can't remember what my blood type is. So I'm going to go type this in actually after the podcast.
I don't think you should feel too bad. I just checked myself last night and figured out I was type O. I didn't know either.
Okay, good. I'll look that up. Finally today, I want to end with a little bit of a rant, I think, about the CDC and the World Health Organization. When we started out, giving COVID updates, we said several times, hey, look, there's a lot of misinformation out there. Just go to the authoritative resources like the WHO and the CDC. And I have just been disappointed over and over again. Earlier this week, in the evening, one day, my phone started blowing up with people texting me and then emailing me about the WHO saying that COVID isn't spread from asymptomatic people. And I spent my entire evening responding to these people saying, that's crazy. I don't know what the WHO is talking about. And it was kind of infuriating. And then the next day they walked it back. So what happened was, Dr. Maria Van Kerkhove, the technical lead for the WHO COVID-19 response, made a statement at a media briefing. And she said, it still seems to be rare that an asymptomatic person actually transmits onward to a secondary individual. It's very rare. So, except
for in all the research that has proved otherwise.
Yeah, and then the next day, I should have just not looked at my phone that evening, because the next day she came out and clarified that scientists have not determined yet how frequently people with asymptomatic cases of COVID-19 pass the disease on to others, and that many cases are thought to be asymptomatic or actually pre-symptomatic, making it difficult to study the rate of transmission in truly asymptomatic individuals. So saying it's difficult to know how many people get it from asymptomatic individuals is very different from saying we don't. And the best data that we have says these asymptomatic people are probably responsible for about 40% of cases. And the CDC says that asymptomatic people are 100% as contagious as others. Again, I don't know if there's great data to back this up either, but it does seem like the most symptomatic time for someone, the most contagious time for someone is the pre-symptomatic time right before they start getting symptoms.
And this idea of getting into like a discussion about pre-symptomatic versus symptomatic just drives me insane. I mean, it doesn't matter whether the person is pre-symptomatic or asymptomatic. I mean, either way, they don't have symptoms and they could still be contagious. So why do we even talk about the difference between the two other than epidemiology?
Yeah. So again, I think their statement about the pre-symptomatic versus asymptomatic was probably just I don't know if that's what she truly meant when she first said it or what, but the WHO can't make mistakes like this. And I still remember the guy's face who came out from the WHO towards the beginning and said, there's no definitive evidence that wearing masks is helpful for the general public. And I remember thinking that statement was almost more infuriating to me because it was true, but very misleading. Like in science, we never get anything that's definitive evidence, but we had extremely strong evidence from prior studies of viruses and the flu that wearing a mask would make a big difference if the general public was doing it. So it's just too bad. And I just want to point these things out just so that people, I don't know what people are to do. I mean, because the CDC, I mean, you could go down kind of the list of things. I remember when they said at the very beginning, they said, hey, you doctors, you have to wear N95s only. And then when we realized we didn't have many, they said, oh, don't worry about it then. It's not that big of a deal. Just wear a
handkerchief.
Yeah. And then the CDC said, no mask for the public. Don't worry about it. You probably just increase your risk of getting it if you wear a mask, which was ridiculous. And then they came out and said, okay, now you can wear a mask since we have masks. It's probably a good idea. And then testing. It's just been this long list of, first they sent out faulty kits. Then the Abbott machine was paraded out by the White House, and they were completely silent about it, even though we knew from the beginning they were big issues. Things that people still aren't talking about, like the mixing of the sample before you put it in. The FDA has now came about with warnings about how poor the sensitivity is. Pooled testing, we've been talking about that for a while. We've known about pooled testing for a long time, and they've still remained completely silent on that when it could be a massive solution. And other places like India and Israel and the state of Nebraska are doing this. LAMP testing, we think, could be a real game changer, and we heard nothing from the CDC on that until finally the FDA gave EUA to a private company to do LAMP testing. So it is an FDA-approved thing, but that could have been something that could be rolled out much more easily than the RT-PCR, the original test that the CDC said we could use. And maybe that's not the CDC's role, is to lead on testing, which I would think that they're the organization that's going to lead on the entire response to this pandemic, but maybe that's not the role. If nothing else, we should at least be able to get good data. And so for me, the straw that broke the camel's back was a couple weeks ago when we realized that they were reporting COVID data and mixing the antibody and the PCR testing data. So we had no idea when they were reporting these positives, whether they were positive antibody tests or positive PCR viral tests, which is completely unacceptable. It makes no sense. It's ridiculous, and it makes it harder for states to know what to do and to have good guidance. So I don't like just complaining, but I just feel like I have to. I've been super frustrated, and we really haven't kind of let the WHO and the CDC have it, but they've got to do better. It almost feels like we're on our own here trying to interpret things and try to come up with recommendations, and we have organizations that should be doing it. And we've got people basically acting completely irrational now. We've got mass gatherings. We're continuing to progress through the openings, which, I mean, I'm tired of being inside and not open as well. But we make these very specific requirements that we set up that we're going to meet or hit before progressing, and then we just ignore them. So, I mean, why set them out? If we're just going to simply give up on eliminating the spread, then we should say as much. If we think all of a sudden that it's not as important because it's not as bad, then okay. But let's say as much. It really feels to me when I look at the data and then I drive around, look at what's going on. It just seems like America's kind of given up on the pandemic and kind of thrown its hands up. And I don't even know what I'm asking them to do.
I mean, you're bringing light to the fact that the WHO and CDC is not exactly always trustworthy throughout this entire pandemic, which unfortunately I agree with. But I think what we probably need to do is give people other options. So where do you go for your information if you can't trust necessarily the CDC or the WHO and everything that they say? I'll tell you what I do. I don't know the answer to that question, but I've followed specific people on Twitter and scientists on Twitter who do a good job daily of looking at the data and talking about the data. And I found that that's probably a better source of information for me. I pick up spikes sooner because of it. I feel like I've got my sort of finger on the pulse of the research and the literature, and I get better information than I would get if I went to the CDC website or the WHO website. And I hate to say that, but it's realistically true. So curating your information on social media at this point is probably a better source of information. And I can't believe I'm saying that. It sounds so terrible to say that, but it's true.
Well, you could follow journals like the Lancet, right?
Yeah, certainly. New England Journal of Medicine, but
I'm being facetious because of
because they've had to
retraction.
Right. So the big retraction on the hydroxychloroquine article that came out of New England Journal of Medicine. I mean, you're right. I mean, so even the people who are reading these articles and interpreting them for us, are trusting that the articles are correct. And it's tough. It's really, it's really challenging. I think you still can have more faith in an article that's been actually published in a journal, because there's been some degree of peer review, as opposed to the preprint articles that often get discussed, and we even discuss on our podcast. But you're right. I mean, sometimes there's even retractions from the journals themselves.
And I feel like I should have had a destination and place I was going when I started that rant, and I really didn't. but I just wanted to get it out there, because it's just been frustrating watching all that happen. So we're not going to rant. We're not going to complain anymore. I think it's important to kind of refocus on what we can do, which is talking about the data, talking about what we're seeing, regardless of political affiliation or political thoughts on opening up versus not opening up, versus masks versus not. What does the data show? And then to continue to each do what we can. For us, that's testing. We've continued to kind of say that we need more testing. We need more data about what's going on. On our last podcast, we mentioned that we were happy to extend testing for those who are protesting, because that really worries me. It worries me what's going to happen in a few weeks from now, the spikes that we're going to see, especially the fact that the vulnerable populations a lot of times that are protesting, and the things that I see, the actions I see happening at protests, which just increase the likelihood of spread. So after the last episode, we started thinking about it, and we wanted to do even more. So if we're not in a lot of these big cities, Mike and I, neither one live in a large city. We're in smaller towns, Lexington, Kentucky, and Bend, Oregon. So some of the bigger cities, we have a lot of medical providers who listen to this podcast. So if you are a medical provider in one of those areas and you want to provide testing, we would be happy to partner with you to actually go to where this is needed more. So if you email us at testing@wildhealth.com, we can help coordinate with you to actually provide some testing for those individuals who have went out to express their desire to protest and to stand up for something they believe in, but they've exposed themselves and probably put themselves in danger. So if you want to do some testing, email us and we'll coordinate with you. Again, it's something we can do and not just complain about the WHO and the CDC. So thanks for listening. Next podcast, no rants, no complaining. We'll just bring you some more research and data as it comes out.
Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.